Welcome back. Now, the South African Health Products Authority, SAHPRA, has approved the use of the Pfizer Comirnaty Vaccine to include individuals 12 years and older. Now, in a statement, SAHPRA said that its regulatory decisions do not translate into a procurement decision, as SAHPRA's mandate is limited to the safety, quality and efficacy of health products. Also addressing the nation last night, President Cyril Ramaphosa announced that the country is moving to level 2 restrictions. So to talk to us about what all of this means and just get some more clarity for the public and country's public health regulations, we are joined by Professor Mosa Moshabela, Acting Deputy Vice-Chancellor for Research and Innovation at the University of KwaZulu-Natal. Professor, good morning and welcome to Morning Live.
Good morning to you, Sakina, and to the viewers as well.
So, Professor, if we can just get stuck in immediately, the NICD confirming that the current surge in COVID-19 infection seems to be showing signs of sustained downward trends. Does this mean that we have now finally, gotten over or reached the peak of the third wave and that we are now over that for the moment?
Sakina, I think what we can say at the moment is that, yes, we have passed the peak where the trend is really coming down. There was a little bit of a delay with a long tail to the right of the curve. But now that seems to be settling, and the provinces that we were concerned about, the coastal provinces, seem to also be declining a bit. The average number on the 7-day average is consistently coming down. The provinces of Northern Cape and Free State are still a little bit bothersome because they don't seem to be settling. But overall, I think that the trend is coming down. We are not yet out of the third wave because to come out of the third wave, we need to be at 15% of the cases that we saw at the peak, and at that time that was about 20,000 cases. So we have to really be below 3,000 cases on average for us to begin to say that we are out of the third wave, and only then can we say that we seem to be safely out of the holds and the grips of the third wave.
So, Professor Moshabela, against what you've just said now, so we had the president last night lowering the COVID-19 restrictions to level 2, and we know that, it's election season. Political parties have already started campaigning for the local government elections. Does this concern you in any way, about the public health risk that might be brought on by the elections and electioneering?
Yeah, absolutely. I think from a public health perspective, I am concerned. I noticed in the speech, especially when you look at the social gatherings moving from 50 indoor to 250 and from 100 outdoor to 500, that there was quite a lot of trade-offs with the need to benefit political gatherings, perhaps religious gatherings, and to ease pressure on businesses. But we are doing it in the context of a variant, the Delta variant, that we know to be highly transmissible. We know that indoor it can actually be carried airborne. And so the infectiousness of the Delta and the fact that it can be carried airborne indoor with the numbers that are being proposed concerns me very much, because I think that we should not take this Delta variant for granted and think that once we come out of the third wave, it's gone. Yes, we are worried about new variants, but this very variant can actually surprise us and actually begin to research. And so I think that with all of those recommendations, it will be important to not underestimate the risk that remains while we engage in trade-offs for other interests in society.
And speaking of those trade-offs, do you believe that they were perhaps a bit extreme, as you say, moving, for example, indoors from 50 to 250? Or would you have liked to see perhaps a little more gradual increase in that capacity?
Yeah, the last time we were at those numbers, Sakina, we were at level 1, not level 2. And it would have made more sense to be a little bit more gradual in increasing the social gatherings. But also, I think that we know that adherence to the numbers is not something that we are good at. regulating the adherence. And so I am even more concerned that those numbers are just simply going to be exceeded. And if there isn't a non-partisan agreement across political parties to ensure commitment to this adherence to preventative measures, public health measures, and also to commitment to vaccination during this political electioneering campaign process, we are going to have a bit of a problem. And we just need to make sure that that sort of social contract or social compact is something that is explicit. At the moment, it's not.
And then, Professor, of course, you speak about variants, and the C.1.2 variant is also one that has been spoken about. Again, should we be concerned about this in addition to the Delta variant and the two coexisting at the time?
Yeah, absolutely. We should be concerned about the ones that still exist. The C.1.2 doesn't seem to be taking hold as fast as the previous variants that bothered us did, but we can still be surprised because slight mutations in some of these variants can actually lead to resurgence. There's also, Sakina, the Mu variant that originated from Colombia and has been registered by the WHO as a variant of interest, not concern, variant of interest, and is still being observed. And that variant seems to be similar to the Beta variant in the sense that it does have a strong tendency towards escaping immunity. And it seems to be a little bit more successful at that than the Beta variant. So I would say that, yes, we need to consider to continue with the surveillance of these variants, keep watch on them from a scientific perspective, but from a public perspective to recognize that the threat of resurgence and the fourth wave, they are not necessarily non-existent. They are really they are a real threat, and we need to continue with measures and not get complacent.
Professor Moshabela, there's of course also the issue of vaccine hesitancy. It's still a major challenge facing many people. The president had to address that particular issue again as well. From your perspective, what do you think should be done? How can this be tackled in a manner that would cause less hesitancy in the first instance? Because people feel that since it seems as though they are almost being forced, those who are hesitant to take this vaccine, it actually makes them actually more doubtful of and fearful of taking the vaccine.
Yeah. Sakina, at a national level, I think the problem that we have is that we are a divided society and we are not able to send out a common narrative, a united message across society. The era of alternative facts, disinformation, misinformation, info-war, all of these things have played an important role in dividing us further and contributing to hesitancy a lot. And also the fact that many of these divisions take hold across political allegiances and political affiliations. That's very concerning, especially when our political parties will also use the vaccine narrative to drive political agenda and priorities. I just think that this is something that should not necessarily be seen as something that benefits certain members of society. It should have been seen from a place of solidarity and social compact. Unfortunately, that is not the case. The second thing we've seen, Sakina, is that we've moved from a phase where people just talk about myths. And because people are getting vaccinated now, people are citing real-life examples of challenges that they face with vaccination from a point of access, from a point of fear, from a point of side effects and so forth, and mistrust of vaccines. And this data shows that even though willingness to take vaccine is around about 62% up to about 76%, we do have challenges that we must overcome. And those challenges, we have to overcome them with empathy. We cannot necessarily, label people who don't want to take vaccines as anti-vaxxers. We have to be more nuanced in our approach. And our healthcare workers, doctors and nurses, will play an instrumental role there because they engage with these people and they are trusted by the population in South Africa when it comes to medical interventions.
The South African Health Products Authority, SAHPRA, Professor Moshabela, have approved the use of the Pfizer vaccine, the Comirnaty vaccine to include individuals 12 years and older. So what does this mean in terms of children being vaccinated?
Yeah.
And again, many parents are concerned. Even parents who have taken the vaccine themselves are concerned about giving the vaccine to their children.
Sakina, I think there's a strong case now to be made for vaccinating children. And if you think about it, initially we thought that COVID-19 doesn't affect children very much from the wild type variant in the first wave, but that has changed over time. We now know that with the Delta variant, the burden in children was quite high. We know children can suffer from long COVID, where they've got prolonged symptoms over an extended period of time, even after the acute phase has resolved. We know that with the vaccination of the adults being protected, the burden has shifted to children, and we've seen outbreaks in South Africa in schools, and this has limited the possibility of children catching up in terms of learning. And I think that, therefore, there's a strong case to be made for children to be vaccinated, especially because, schools are daily gatherings and social gatherings, and they can contribute to reinfections in the households as viruses moves from schools to households through these children. So we have to really vaccinate children. The thing that excites me about this process in South Africa is the Sinovac trial, where the Sinovac is going to be tested by Numalax and Sfakomahat University. The approval by SAHPRA of the 12 to 17-year-old is based on international data. What I think SAHPRA needs to do is to really go on road shows to engage the public on the data that they have used to make this decision, because it's not something that originated in South Africa, and there's a lot more effort on the side of SAHPRA to actually convince the South African public why they made that decision and how safe kids are. Kids are not just small adults. So we need to show that the data is there and is compelling.
And a few things about that, Professor. Firstly, as an adult, I figure, I am past the age where I want to have children, so I'm not too concerned about reproductive issues and the like, so I am happy to take the vaccine. But I'm still a bit cautious about my 20-year-old daughter having to take that, because I don't think I have enough information at my disposal. Do you think that that's fair?
Yeah, no, I think that the long-term effects are concerning. But, Sakina, I would say that the long-term effects of COVID-19 in these children is something that would be more worrying for me. The concern that you raise in terms of the certainty around the long-term effects in young girls, reproductivity and so forth. So far, we don't have the evidence. But what you are saying is not that, the evidence is the concern. It's really about how much aware, how confident are you in terms of, and everyone else in the public really, in terms of the information that is out there. And that's where I really think that public engagement is the most important part of this process, because we have to build the trust that is needed in the data, in the institutions, to make sure that we can get parents to support the consent of the young people. At the end of the day, no one will be forced to take this vaccine. But I do think that it's only fair when people make informed consent, and that information needs to be abundantly available. SAHPRA needs to engage in those processes.
And still on the question of consent, and we had a question of the day on Friday talking to the issue of the Sinovac trial for children. And on that score, how do you go about getting consent from a 6-month-old, from an 8-year-old? How does that work?
Yeah, no, I think that is established in medical practice. So if people are less than 12 years old, usually the consent comes from an adult parents. When people are between 12 and 16 or 12 and 18, just depending on the condition you're dealing with or the medical intervention, those young people, the teenagers, will give consent. But the parent also has to give assent. So it's a joint consent between the child and the parent. In some instances, but it doesn't apply with vaccines, We also have situations where consent for children can be given by institutions like medical fraternity or courts and so forth. But in this case, I think it will be more a consent jointly by the child or the teenager consent and the parent.
And that's an interesting question. I can tell you, people's views on that are quite strong. But it's an interesting discussion all the same. And then, Professor, talking about, the long COVID symptoms, and this is something that personally I feel we don't speak enough about, because knowing people who've had COVID still struggling with some of the symptoms of the after effects of COVID, the long COVID, for months, and some in certain instances almost going on a year or so. Can you still get those long COVID symptoms after vaccination?
Yeah, I think that this is really important question you're raising. I think we have data that is emerging, and I say emerging because it's new data. It's from only a couple of sources that demonstrate that people who have been vaccinated have reduced chances of long COVID, and they recover quickly from COVID-19. So I think that the data is pointing in that, and it's both in terms of laboratory testing and clinical testing. I think the data, Sakina, is pointing in the direction that vaccination, having immunity prior to infection, helps people to not have a severe form of disease, helps prevent the virus from spreading throughout the body, because this long COVID symptoms really have to do with the fact that the receptors that the virus goes for can be found pretty much everywhere in the body. And when that has happened, and especially if people do not have the strong immune system to be able to fight it off during the acute phase, these symptoms can hold. So vaccination helps to prime the immune system to respond better. And we are seeing that long COVID can be reduced with vaccination. So that, for me, I think it's positive. And you are right, we don't talk enough about the long COVID debilitating symptoms, and it's something that we need to pay attention to. But vaccine is promising to make a difference there.
And of course, the vaccine hesitancy once more. If we could, Professor, just sketch two scenarios, best case, worst case. If the people who are still hesitant continue to be hesitant and refuse to be vaccinated, what are the best and worst case scenarios that could basically come from that?
Yeah. So I think that, Sakina, we have a case scenario that we are seeing in the U.S. Where, in a place like Florida, there's been a lot of resistance to vaccination, largely linked to alignment to Trump policies and political perspective. Right now, what has happened is that they've seen so many cases, so much hospitalization beyond what they saw in previous waves. And that is the worst case scenario. When we don't vaccinate, we're going to deal with further cases, infections, hospitalization, severe disease, and death. And that's not what we want to see. But if you contrast that with other places, like what we've seen in the UK, what we are seeing in Ireland, what we are seeing in Canada even, where there is high vaccination coverage, we are seeing a situation where hospitalization is reduced and especially death is reduced. And I think that, for me, that is the best case scenario that we have at the moment with the vaccines we have. In terms of eliminating COVID-19 infections, that will only happen when all countries in the world are protected from COVID-19, because then that can prevent new variants from emerging, which is why the inequity of vaccine distribution throughout the world is such a problem in terms of herd immunity. But in terms of severe disease and death, we can definitely get there. I think in South Africa, if we hit about 50%, 60% of adult population and we comply with these public health measures, we will get there. And similar to Ireland, when we get to higher levels of coverage, we may even have to ease some of these restrictions, because then we would be disrupting the spread of infection so much that we'll be coming closer to herd immunity.
And is it possible to avoid the fourth wave predicted for later this year at this point, Professor?
It's unlikely that we can avoid it altogether. I think we will have it, but I think depending on the vaccination, if in the next couple of months we increase, we are at 18% coverage of full vaccination right now, about 26% or so in terms of partial vaccination. If we can accelerate that, Sakina, we will get to a point where come the fourth wave, there will be limited hospitalization, therefore pressure on hospitals, there will be limited death. And that would bode well in terms of bringing us closer to normality. And that's really what we are pleading for. But we can only do that with vaccination at this point. Otherwise, these surges of infections and waves, they come at a high cost and often quite unpredictable.
Professor Mosa Moshabela, thanks so much for your time this morning. Professor Moshabela is the Acting Deputy Vice-Chancellor for Research and Innovation at the University of KwaZulu-Natal, talking to us there about President Cyril Ramaphosa's address to the nation last night, and of course the South African Health Products Authority, SAHPRA, approving the use of the Pfizer Comirnaty Vaccine to include individuals 12 years and older. So I'm sure you have very strong views about all of this, and as I've said, I think by now people have made up their minds as to whether they will or will not take the vaccine. It's beyond a point of trying to convince them, but it is real. If you know people who have died of COVID, you would know that it is real. At 7 o'clock, let's bring you the latest news with Leanne.